Hello, good afternoon to all of you. I am Dr. Praveen Chandra from Medanta Hospital here in India, and my colleague Dr. Abhinav and Dr. Ankur are going to be with me for this case. So, first of all, this is a very young patient, 38 years old, and Dr. Abhinav is going to explain the demographic profile and the history, and then I'll take it forward.
Yes, so hi everyone. So this is our patient, 38-year young gentleman. So he was a past history of chronic stable angina. He was managed on the basis of chronic stable angina from last 2 months. But these complaints of angina were gradually progressive over one and a half month. And followed this, he was evaluated, and despite on medication, he was symptomatic. Even after 100 meters of distance, he was having significant angina. And the CT angio was done on in the last month. It revealed LAD having 100% occlusion. And for the same patient came here for the further evaluation, and we did angiogram, which revealed again the same LAD, which is ostial 100% blocked. So this patient is having a family history of coronary artery disease, although he is not a smoker and tobacco chewer. So he's also not diabetic, non-hypertensive. So further case will be discussed by Dr. Chandra, sir.
So basically, this is a very interesting issue that he is only 38 and he has come with such a high grade occlusion of the proximal LAD and appears most likely because of his genetic predisposition. Okay. He is not obese and he has no other major risk factors. So we did the angio, and the angio showed that the right artery is normal. So show the angio, please. So you see the circumflex is okay, and the LAD is almost from the ostium, and there is some filling which is happening through collaterals, and these are collaterals coming from some of the OMs to the diagonal. And our right coronary artery, we take a simultaneous injection, we see that the filling is happening up to a bifurcation of the diagonal. So approximately about 15 to 20 millimeter of occlusion. And we are just going to start with the antegrade pathway. And antegrade, we are chosen the Fielder XT wire. So we always choose the Fielder XT wire because many times these are very micro channels which are not seen, and we are able to cross it. So let me try this. Okay. Check, please. Yeah, check. So you can see that. Check. There is some thrombus kind of thing over there. What is that? That is a branch. Okay, so we are now in that nipple. So I'm in that nipple. I will go very slowly. Do not try to push too hard. Where? Okay. Going slowly. Epicranial. So I've just entered the nipple, and we will see how it progresses. I'm going very slowly and trying to rotate the wire a little bit. And the RC is out.
RC is slightly out. I haven't
Show me.
engaged it very well.
Check. Wait a minute. So we have to re-engage the RCA. Where was
Yes,
it?
here it is. Just
Okay.
you can take the shoot.
Oh.
Yes.
Okay. Okay. Check, please. Looks like that we are in the right direction. He has just injected from the opposite coronaries. I'm not every time this is happening here. Just wet it. Okay, I'm not very happy with the direction as of now. Check, please. Check from the I'm not very
Yes.
sure.
Just a second, sir.
Check. Check. This could be okay. Can we check in other views? Go to some other view, please. No, iliocranial, iliocranial, iliocranial. Okay, check. Not very sure. I'm not getting a lot of resistance over here, which should not be there. Epicranial again. Check.
Integrate there is.
Check.
Yes.
I think I'm already entered the channel. Can we take a shot to see? Yeah, so looks okay to me. Yeah, this is fine. So we have crossed this rather quickly, and so we are quite into the distal part of the LED now, and I'm quite happy that we are in the right channel. So what is the next step? So we can take a, yeah, we can take it out because we are already sure that we are in the true channel and we have entered into the main vessel. Okay, so let's
1.28
take a
or 1.5.
one balloon. I think a normal maybe a 2 mm balloon should be okay. 215 or 220 because it's a long lesion. And the way the wire has gone, it appears that it is not very heavily calcified or something, but nevertheless, we will see. So this is a 218,
15.
So this is a 1 point, sorry, a 2 into
15.
15. Okay, connect please. Yeah. So it is moving easily. Yes, yes. So this patient never had any MI or anything and has good collateral. So we were not sure what will be the nature of this lesion, how easily we will be able to cross it. But anyway, okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Deflate. Check please. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we are going up to 10 atmospheres and then we will check. Okay. Deflate. 10, 12. Deflate. So there we are. Okay. So we'll do a IVUS and maybe a OCT also if required. So let's first do the IVUS, then we'll see if we need the OCT, we'll do it. Okay. Yeah. OCT. OCT. So So this is the first IVUS run we are going to do now. Okay. There is some plaque in the left main, and we are about to enter into the LAD. You can see that the LAD is diseased. So normally we go from the distal to the proximal, but here I'm trying to just look at the ostium of the LAD more carefully. Okay. And all this is plaque. You can see how much it is full with plaque.
Diagonal or
Okay. And that was the diagonal, and now we are in the distal part of this LED. Okay. Yeah.
It will grow, sir.
It will grow because it is a spasmodic situation, so it will grow. And as you can see here, so tell us the sizes, please.
So what will be the plan? Will you do
The
a
plan
cutting
is I
and
will use since it is not calcified, there is no need to use any kind of a shock wave or anything of that sort. But certainly, I would like to use a cutting balloon.
cutting?
Wolverine, please,
Wolverine 3.
and give some nitro.
Yes, given
Take a
on that.
shot. Take a shot. Okay. Yeah. So now the other thing is
Plaque
that
shift.
this diagonal is, there is a chance that we might lose this diagonal. So why not try and wire this? Okay, give me a wire, please.
BMW.
BMW.
Maybe, sir, LED is diseased in middle part also.
We will see. We will, check. Show me the first angio, please. So because there is a suspicion that the LED might be having a disease and beyond that septal. Next, please.
Hmm.
Introducer. Next shot.
Hmm.
Next.
Introducer देना.
Yeah. Okay, let it be. Let it be. Yeah, there is something, beyond
Introducer.
that septal. We will see. Maybe it is just a competitive flow which was there earlier, which is looking like this now. Now. Okay, so I have taken another wire and I want to go in the diagonal also because it's a very big diagonal and I don't want to lose this diagonal. Okay. RO caudal, please. RO caudal. Okay.
AP.
Okay, AP.
Pistols. Yes. Yes.
This is going in a very funny way. So what I'm doing is I'll put this BMW in the main vessel LED and I will try to use the same filter XT because there was some difficulty in going through this angulated tight lesion, which will be easier with the filter XT. Okay.
Plaque shift. Earlier diagonal ostium was good even in
No,
IVUS.
there was some disease there already. There was some disease on the angio also. Okay, where is the wire?
Mid LED.
Yeah. Okay, 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 okay. Okay.
More. Yes.
Actually, in IVUS also, if you see that there is a lot of, plaque sitting at the ostium of this diagonal. Mhm. Yeah. So I have entered into this diagonal now after some difficulty. Okay. And check, please. Yeah, that's fine. So we are good to go. So I'll place it in the bigger branch, which is the proximal one, or else I can park it here also. Okay. So take the same balloon, please, 2 mm.
Ready.
So I will dilate this ostium also, and then we will see what strategy we have to use for this. Okay.
Fire.
No problem. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. 10, 12. Okay. Deflate. Check, please. So we are now checking it. Okay. Now this looks much better. So the diagonal is a very big artery, and at least 2.75 or 3 maybe. And the LAD is also quite a big artery. So I will try to do it with a 3 mm balloon, a cutting balloon to the LAD first. That is one strategy. The second is that we just put stents straight away. Okay.
Myocardial bridge is there in mid already.
Yeah. So we give some nitro, please, and give me a 3 mm, 315 cutting balloon. So I'll take a 315 cutting balloon.
ACT.
Yeah. Just to get some more plaque modification. So we are taking a 3x15 Wolverine to modify the plaque before we finally place the stent. So why we are using Wolverine are two reasons. One, that we really want to optimize the intervention angioplasty before we either put a stent, or we might even consider doing a drug-eluting balloon. So we'll see how it goes. Okay. Because why we are doing so? Because he is a very young patient, and I really want to avoid putting a stent starting from the ostium in case I can. Check, please. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 12, 14. Deflate. Okay. Check, please. Check. 12, 14. Deflate. Okay. Approximately. Let's go to the iliocaudal. Iliocaudal, please. Iliocaudal view. So I want to dilate up to the ostium with this cutting balloon and try to see what we are able to achieve. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Okay. Deflate. So at 14, it becomes like a 3 will become about 3.3, 3.4, deflate. Okay. Okay, check please. This looks very nice. Okay. I mean, at least majorly, it looks quite good. Okay, epicranial, please. LED is looking very good now. And
Diagonal ostium.
diagonal ostium, we will do something about it. We can even do a
Cutting
2.5, yeah, 2.510. 2.510, please. Okay. 2.510. Yeah, that's right. Take a shot. Okay, so we will do this with a 2.510. And you can see that the LED looks very nice actually. Yeah. Show me a 2.510. Yes. We can even run a laser through this. So I'm going to do this. So this is a 2.5 into 10. I mean, we already know that in bifurcation lesions, I mean, if we don't put a side branch stent, it is better. And even if the main vessel we want to avoid. So let us see how it works. Okay. Okay. Check, please. Check. Yeah, that's fine. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. So this is a 2.5 into 10 Wolverine, and we are doing a dilatation at the ostium of the origin of this diagonal. So we are treating this like a
negative
bifurcation. Deflate, please. Let us see how it looks. Okay.
Ostium diagonal.
We can do one more.
Yes, sir.
Okay.
There's some thrombus formation. ACT.
ACT. Okay, check please. Okay, go up. 2, 4, 6, 8, 9, 10, 12. Deflate. Okay, check please. Looks much better. Looks far better. The flow in the diagonal is very good. And the LED also looks very good to me. Yeah. Just a minute. Okay. So, okay.
Proximal LED has some haziness.
Yeah, let us look at the other views. So, RA caudal, please. RA caudal. Have we given enough heparin? Check, please. In fact, it looks very good. LED looks very good. So we can do one more dilatation with a 3 millimeter balloon. So the proximal part from the ostium up to the first 10 millimeters, 15 millimeters looks extremely okay to me. And I'm doing some more inflations before we finally decide whether we put a stent or a DEB. Okay. How much?
250.
Okay.
2000.
2000 more. Okay, so this is the same 3 millimeter balloon which I have taken for the LED redilatation. Okay. Where are we?
On that wire.
I don't know why it is behaving like that. Now
Now
it is
it is.
better. Okay, check please. Check. Yeah. Okay. Okay. Go up. Wow. Okay. Just a minute. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. 12, 14. Okay. Deflate. Okay. Yeah. Check please. That's too much. Go up. 2, 4, 6, 8, 10, 12, 14, 16. That looks nice. Okay. Deflate. Short please.
Better
In fact,
flow.
now everything is flowing nicely. You see that? Okay.
Diagonal has a good flow.
Yeah, the LED is also very well dilated now. Diagonal is flowing nicely. Okay. Show us epicranial. Where is the wire? Oh shit.
That balloon.
नहीं. Check करो. So the diagonal is flowing nicely, and LED is also looking very good to me. I am actually tempted for a drug eluting balloon. Yeah. What do you say?
Yes.
So can we do a IVUS? Shall I try to put this wire back into this diagonal? So this is the problem with the Filter XT wires because they move rather fast and they get pulled out a little bit faster than others. No. It is damaged. Wire is damaged already. Take this. Okay, iliocranial. Iliocranial.
BMW.
Okay. So I will take a shot now, proper one. Check halka sa little. We are pulling everything. Why have a light hand? Check. Yeah, that's much better. So the flow in the LED is looking good. And I think we can. Let's do an IVUS and see. IVUS, please. How much is the? This diagonal is flowing quite well, actually. Okay. So this is a 3 mm segment, normal. And this is the bifurcation. And here also, I mean, the lumen is quite good. There's some thrombus there. I think this will go away. And nothing much. So I think we are okay.
Yes.
We should do a. So how is this? What is the size of this vessel?
3 almost.
3. Okay. So we'll take a 3 into. How much is that? Let me see. Yeah, maybe a 320.
What about diagonal?
Diagonal, we'll put a wire there
BMW.
and then see if we really need to do anything or not. Give me a wire, BMW, please. So that wire was not looking that good. So we are changing this to a BMW in the side branch. Normally, we can even not even put the wire, but just as a matter of more precaution, I'm doing it.
It's regarding, will you dab to diagonal also?
Yes, yes. Mhm. Okay.
Hmm. Small branch.
It's going in a smaller branch.
You change ना आर्यो करना थोड़ा येलो कर लो येलो
Just check. No.
yes
Okay. So we should do a
dab to
depth to the
diagonal
diagonal. So we'll do a drug eluting balloon
2.5
2.5 into 10.
10 15
Yeah, 10 or 15 should be good enough. Okay. Give me a balloon, please. This is fine. 2.5, 10. 2.5, 10. So we are taking a 2.5 into 10 millimeter drug eluting balloon to the diagonal. And then we will do a drug eluting balloon to the LED proximal area. Because we saw that the luminal area was quite nicely achieved in the IVUS in this. How much is the area now? Luminal areas achieved? Can you tell us? Yeah, this is looking good. Yeah, show me here. Yeah,
that is more or less thrombus है वो
5.6 is quite okay. Yeah, that'll be fine. Connect. Just a minute. Just a minute. Okay. Connect, please. Check. Check. Oh, that's fine. I think it's okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8. So this is a 2.5 into 10 up to 8, 8 or 10, 10 atmospheres, and we'll keep it inflated for about 2 minutes. Okay, 2 minutes. And for the LED, we will take a 3
3
or a
3
3.5.
25
3.5 we don't have. So either we can take a 3 or a 3.5. So the IVUS, the vessel looks quite big actually. This is distal or proximal?
here this is
Okay,
going to
come down. This is about 3. And yeah, here it is about 3.5. We can take a 3.520 actually. Yeah. Yeah, low pressure. 3.5, 20.
3.5, 20.
Let it continue. So it's a 1 minute of inflation in the side branch.
Magic solution.
320, please. And this is a magic touch from Concept Medical. And we are using a 2.5 into 10 millimeter sirolimus eluting balloon, which gives 1 microgram per square millimeter of this drug. So this is 1 minute 41 seconds, and we are going to stop it now. Okay. Deflate. Yeah. Don't mix the wires.
Nice. Separate kiya hua. Yeah.
Okay, so we'll keep it like this over here. Just keep something.
Yes.
Sheet.
Kar deta.
Yeah. Okay.
Hata ke.
Give me another depth 3.5, 20. So let's have another balloon. So we'll take a 3.5 into 20 drug eluting balloon. Again, a sirolimus eluting balloon for the LED. So give me that DEB, drug eluting balloon. Okay. Okay, yeah. So this will be fine. We will take this 3.5 sirolimus eluting. Now this is a different one. This is a solution SLR. So we are taking, but both the drugs are the same, so it's okay. However, the release techniques are different. In Concept Medical's Magic Touch, it is phospholipid core. Here, these are small globules which are made, and they just release the drug over a period of time. Okay. Okay. Okay, so this is a 3.5 into 25. And can we check RO caudal? RO caudal. Check, please. Check. Okay, I think this should be fine. Okay. Yeah. Okay, check, please. Fine. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9. So we have gone up to 9 atmospheres using this solution SLR, and at 9 atmospheres it is 3.58, 3.58, and we'll keep it for a period of about 2 minutes if possible. However, we see that there are some drop in blood pressures here at this stage, but we will see. If he tolerates, will be good. I don't think he will tolerate too much, but it's already 50 minutes. We'll finish at 1 minute 30 seconds. 1 minute 30 seconds. Pressure is improving already. Maybe he's recruiting the collaterals.
Yes, rhythm is changing.
Some broadening of the QRS.
Quite
broadening of the QRS.
Pressures are also different.
Deflate. Deflate. Okay.
Better.
So we have deflated the balloon.
We want to put a kissing one. diagonal.
I want to see first. Okay. Looks quite nice. Both the arteries are flowing well. There is no pinching of the circumflex as is
Ostium is good.
expected, and the ostium is looking very clean. Epicranial, please. And the diagonal is also flowing nicely. So with this, if everything looks good, we should be fine. I think it's quite good. Yeah. The flow in the diagonal is also reasonably good. We'll keep, I mean, this LED is looking beautiful.
Yes.
Yeah. The only thing is I see that there is probably some dissection or something. Can we show us the back previous shot, please? I mean, in this view, it is very good. And next view, please. This view also, more or less, it is okay. Go to iliocranial. And the pressures are very good. The ECG is absolutely normal. And we'll see.
Good.
Yeah.
It's fine, sir.
Yeah.
That is one branch which is crossing.
Yeah, there is a branch which is crossing somewhere. Okay. Iliocaudal, please. Yeah. Okay. I mean, there is some little haze there, but I think it'll just wash out slowly because that's maybe part of some,
thrombus only.
Yeah, thrombus, which will wash out.
And in that view, it is just a dye filling defect.
Yeah. Let it continue. And the best part is that you see nothing at the the ostium of the circumflex, and is absolutely healthy. Ostium of the LED is also looking much better, and the diagonal is flowing. The LED is flowing. I think everything is okay. So we should leave it as such, and continue medications for him. That'll be nice. Okay.
Yes.
Yeah. Okay. So we are done, and come to the iliocaudal, please. So we'll take a final shot in this view, and you can see.
Yes.
This looks very good. The flow is TIMI3 in both the branches, the diagonal and the LED, and ostium of the circ is fine. No major recoil and no major dissection. So we are done. Okay. Yeah. So this is, something which we try to do now for, patients who are below the age of 40 years, and this is a 38 years old. And especially when the stents have to be positioned at such critical locations like ostium, etc., where there is always a chance that either we have to put the stent from the left main into the LED, then you jail the circumflex, or if you try to put it at the ostium, there is something which will some plaque effect on the circumflex ostium.
Secondly, that LED D1 bifurcation.
So this was the LED D1 bifurcation, and we have seen in our experience that that bifurcation lesions also now can be treated with pure drug-eluting balloon methods. You want to say something more?
I think young patient with these good results.
Yeah. So looking at his age, I think this is the good solution for him for the long run. Okay. Thank you very much, and hope to see you in the next session.